everybody. So I just want to say thank you to the Scleroderma Foundation, Tina Berger, for the invitation to speak today. I'm, Tina said, I'm a bone marrow transplanter, so come into this from a different direction. I was asked to talk about an overview of hematopoietic cell transplantation in scleroderma, and as well as some of the Stanford experience. Let's see. Okay. So as part of just the overview of the talk today, I was going to go over what are some of the data that support autologous transplant for scleroderma, a little bit about the Stanford experience, and future directions. So kind of the basic slide of scleroderma. This is more to help me to organize my thoughts. As Dr. Katsumoto earlier described, the systemic scleroderma being a heterogeneous systemic autoimmune disorder with the two forms, the limited and diffuse cutaneous forms, limited being more the distal affected areas of the skin with relatively good prognosis, and the diffuse with more extensive skin involvement going proximal and involving more extensively visceral organs and having a poorer prognosis. So the pathogenesis of scleroderma, I have my own picture slide, similar to Dr. Katsumoto's, again, also to just sort of organize the thinking around how we approach treatment of scleroderma, is that we think of it as a cycle of pathogenesis, starting with the vasculopathy, followed by inflammation and fibrosis. And basically, the autoimmune syndrome creating a vascular injury that activates endothelial cells, that then in turn results in an recruitment, activation, proliferation of leukocytes, that's T cells, B cells, macrophages, dendritic cells, that cause a pro-inflammatory environment to be created. And once that's created, I don't know if I can, you can see on the bottom of the screen, these are the T and B cells getting activated, creating a pro-inflammatory environment that results in activation and differentiation of resident fibroblasts into myofibroblasts, which then create a profibrotic environment, setting down more extracellular matrix and leading to the vascular remodeling and excessive fibrosis that you see clinically. So treatment, again, this is my basic slide, and really to organize around the treatment for scleroderma being perhaps not standardized, but requiring a very comprehensive interdisciplinary approach. The first standard of care, first line standard of care, seems fair to say it's focused on immune suppression with MMF, cyclophosphamide, methotrexate kind of agents. But then there are the newer agents, as were spoken about, anti-inflammatory, more directed anti-inflammatory and anti-fibrotic agents like tocilizumab and nintedanib. And then again, your treatment being more focused toward trying to prevent progression of in the organs that are involved, and the various agents for skin, kidney, lung ILD, and lung the pulmonary artery hypertension. But hematopoietic cells transplant probably we can say has emerged in recent years as a treatment for more the diffuse form, of course, when it is refractory and rapidly progressing with sclerosis and cutaneous sclerosis and organ involvement. So what then is the proposed mechanism of autoimmune disease remission when you do an auto or an autologous transplant? So back to the slide, pathogenesis slide, the basic principle of an auto transplant would be to rebuild a new intolerant immune system by using the high-dose therapy of the transplant. And in general, what we're trying to do is have a major impact on the eradication of the autoreactive immune driver cells. And that's where that X mark is there. That's probably where the transplant is impacting. And that by doing that, we can reestablish normal T and B cell regulatory networks that then allow us to break this cycle and allow normalization of tissue architecture and hopefully reverse the fibrosis. So there was in 2018 a position statement from our organization, the American Society of Blood and Marrow Transplant, that systemic sclerosis is an indication for autologous transplant. This was actually about the time that I met Dr. Katsumoto and the Scleroderma group at Stanford, is how we connected initially. And what was in this statement was that their final conclusion was that auto transplant would be considered a standard of care for patients with severe systemic sclerosis. And the European Bone Marrow Transplant Group, which is the EBMT, followed shortly thereafter in 2022 with the same conclusion. And this was based on expert panel that was reviewing the current evidence and provided this recommendation. And basically it was mainly based on these three randomized clinical trials of transplant being shown to be superior to cyclophosphamide for the treatment of systemic sclerosis. And this is the table sort of reviewing the three trials that made this recommendation happen. There was and they are separated in time. ASSIST was quite a while ago in 2009. ASTUS, which was more of a European trial, and the Scott trial, which is the more recent American trial. There were, you can see very small numbers. In the ASSIST trial was a 19-person trial, and there were different approaches. So I put down what is important in transplant mobilization regimen, how you collect stem cells from the patient, the stem cell purification or modification, and the conditioning regimen. And those are things that are unique to transplant, and they were different actually between the three trials. Probably the most impactful one was the Scott trial that was done, that was reported in 2018, which led to the change in position. But the main thing to notice is that there is what we call CD34 selection of the graft, so that's manipulation of the graft to take out the activated or T cells and your activated lymphocytes that we think are drivers in systemic sclerosis. So that was felt to be important to include, as well as these regimens which are very lymphotoxic, meaning trying to still drive down those immune cells. And then the outcomes of the three trials are shown here. Sorry, I don't have a good pointer, but that what was found in all three trials was that there was an improvement in skin scores, in event-free survivals, overall survival over the Cytoxan arm. The Cytoxan arm was the control arm. It was a pulse Cytoxan monthly given IV for a year. That was the alternate arm to the transplant. And that, of course, treatment-related mortality is always a concern with high-risk procedures like transplant. These are relatively low numbers, or they're actually low numbers that we accept even for lymphoma. Auto transplant is 3%. It's quite acceptable, but the 10%, a little bit higher. These were probably infections, and that were primarily a part of this. But you can see the Scott trial in the lowest row went out to 72 months of follow-up. So that's pretty impressive follow-up. They also used a unique endpoint marker, which is called GRCS Global Rank Composite Score, which was actually probably more meaningful than just overall survival or event-free survival in terms of outcome, because it incorporated not only event-free survival and mortality, but also improvements in your forced vital capacity, disability index, patient-reported outcome measures. And still showed improvement over the cyclophosphamide arm. So this is a little bit from the results of the Scleroderma Scott trial, which stands for Scleroderma cyclophosphamide or transplantation. That's basically what that means. But anyway, the top row of figures is really this GRCS outcome at 54 months. And basically, the color coding is green, shows improvement. The left is the transplant. The right is the cyclophosphamide, and the components of the GRCS score are listed below. And you can see, just sort of eyeballing, there's more green on the transplant side over time versus the Cytoxan. So favoring the transplant arm in improvements. There were also the standard event-free survival and overall survival that were also reported in this study. And you can see the red being the transplant arm, looking superior to cyclophosphamide alone in terms of those survival measures. Also at the bottom was the need for DMARDs to be reinitiated after the transplant versus cyclophosphamide, and it was also much improved, 9% only for once you had a transplant, going back on more therapy versus the cyclophosphamide arm being 44% back on therapy. So what are the things that you get concerned about with auto transplant? Of course, it's the adverse events. It is a high-risk, considered high-risk procedure. Certainly in a population, you don't want to cause more disability or harm. So what did it look like in this study versus cyclophosphamide alone? And over a 72-month period, certainly serious adverse events like infections, like low blood counts. Those were things that occurred on the transplant side, obviously over the cyclophosphamide arm. It tended to happen in the early part because transplant is a one-time therapy and everything toxic happens in the first month, pretty much. And so that's actually what was discovered in this trial, that the patients that underwent the transplant arm on the left side for these bar graphs, all the blue is the adverse events being serious were in the first several months of the transplant course. You do see ongoing, though, events still happen in the cyclophosphamide arm over time because you can, over time of getting therapy, accumulate toxicities of infections as well. So anyway, it did favor cyclophosphamide as being lower in the early period, but perhaps didn't really change what the outcome of survival and event-free survival. And then transplant-related mortality always 3 to 5%, like we said, throughout the course of the transplant versus none for obviously not treatment-related mortality from the cyclophosphamide. So there has been even longer-term follow-up. So I know one of the questions before was how long do these benefits last? And so they followed out beyond the 72 months. They followed out actually 6 to 11 years, these patients. And there were about pretty good retention. 75% of the transplant group and 46% of the Cytoxan group completed this follow-up study through 11 years. And this was reported in an abstract form by Dr. Sullivan, who was the primary investigator on the Scott trial. But the overall survival in the transplanted arm still seemed at 11 years to be quite good, 88%, with no deaths after the 6th year of post-study. And in the Cy arm, 53% versus the 53% in the Cy arm. So there was an actual 35-point difference there. Other outcomes that were point to long-term benefit of the transplant seem to be organ failures, less developed in the transplant arm over time versus 6% or 6 patients developing it in the Cy arm. And at follow-up, only 8% of participants treated with the transplant were on DMARDs versus 39% back on. So similar to the earlier 72-month mark. Body weight and performance scores, these are ECOG, is your performance status, just sort of on scale. Also much better at 90% normal versus 61% in the Cy group. And body weight improvement in the transplant arm superior to the Cy group over this time period. And maybe, in a little bit more into the psychosocial aspect, more than half of the group in the transplant arm were back to work versus maybe only a third in the Cy arm. So these were important things to notice with the results. Also to note was that there were no secondary cancers that were reported in either group over the follow-up period. So what is, actually, unfortunately, Stanford did not participate in the Scott trial primarily, but there were correlative science that was done around samples done on the patients on that trial that were performed by Stanford investigators. And so I will just mention those. Dr. Robinson's lab looked at, so you would have blood samples before and after certain time points after the transplant or after Cytoxan that could be studied. And so what Dr. Robinson's group looked at was he looked at the IgH repertoire, which is immunoglobulin heavy chain. That's sort of the immune repertoire that comes back after you transplant the patient or versus Cytoxan. And what they found was that there was a sustained increase in IgM isotope antibodies and a reduced clonal expression in the IgH repertoire following transplant. So what's the interpretation of that? Is basically, it suggests that the myeloablative transplant compared to the Cytoxan arm depletes the autoimmune B cells. And post-transplant, the B cell pool is repopulated by naive B cells, as marked by this IgM appearance. IgM is an early B cell. So it suggests that new naive B cells are actually recovering after the transplant happens. And that leads to an auto-tolerant stabilization of the B cell repertoire. And therefore, hopefully, is the path to eliminate those pathogenic B cells from not coming back. The second investigator was Dr. Utz. His lab looked at autoimmune antibodies or autoantibodies formation before what was present before and after getting the transplant versus staying on Cytoxan. And this study actually identified maybe new markers, anti-cytokine antibodies that were in the transplant patients. There was a certain profile of cytokine antibody that was present or to antigens that were present in the transplanted patients that seemed to be a marker for favorable clinical outcome. And that might be a way to, that this might be a biomarker possibility to follow or to actually pick the patients that may do better with a transplant before they have the transplant is kind of the background on that. And it really didn't change with the Cytoxin. You can imagine there was no intervention that changed that cytokine profile for Cytoxin. So what do we do at Stanford? So the auto transplant at Stanford really is based on the Scott trial regimen. So we follow it pretty closely. We follow it exactly, and that means it is a myeloablative conditioning, full dose chemotherapy and radiation. And the schema is shown down here. It's a -5, 4, 3, 2, 1. We give the regimen -5, 4, 3, 2, 1, and then we give the cells on day 0. And so what happens is the patient is harvested for their stem cells ahead of time. We manipulate that stem cell product to select for CD34, just the stem cell component, and deplete the autoreactive lymphocytes, hopefully by doing that. And then we freeze them away for the patient to receive once they come in inpatient to do the regimen. This is probably about a 3-week regimen in hospital that happens. You do meet the radiation oncologist because it is still considered a reduced dose radiation, but it is total body 8 gray that is given prior to cyclophosphamide and antithymocyte globulin, those red points. That's an anti-T cell therapy. Cy is a lymphocyte depleting therapy. All is meant to knock out your lymphocytes, but also knock out your stem cell component in your marrow. So this will wipe out the marrow temporarily, and you'll need to recover with the cells your stem cells that you harvested earlier. In terms of eligibility, we do take probably the younger age, which is less than 70. That doesn't mean that can't be pushed further out like we are doing in lymphoma as well. We're taking even 75 plus patients when in good shape. And again, the thing to remember or to note is that we do take the advanced patient, of course, the diffuse cutaneous sclerotic patient, and with the advanced modified Rodnan skin score, as you can see here, and with pulmonary involvement or renal involvement is accepted. But there is a threshold that we can't take if you are too advanced with that you're not able to tolerate this level of intensity of conditioning. Of course, we'd have to we would look at that. But otherwise, we coordinate with the rheumatologists in our group to select for these patients and welcome patients who would want to learn more about this. I was brought a patient case. We've done a few. This is a patient I share with Dr. Katsumoto, actually. And she was 55 at the time I met her. She had had an 8-year history of diffuse cutaneous scleroderma, positive ANA, positive SCL70 antibody, Raynaud's, maybe sounds familiar to some of the folks here, myositis, GERD, ILD that was recently worsening, and worsening skin disease after stopping her myofortic over the past year, and that it wasn't getting better, but just continued to worsen her skin symptoms despite restarting her systemic therapies. So she underwent this Scott trial designed regimen with us. With the CD34 selected graft. This is what she shared with us, her pre-photos before, where her Rodnan skin score was 40. And you can see the puffiness and the contraction in the joints and the quite uncomfortable. And she is actually now about 3 years post now. So, but this was her 1-year photographs. Her skin score had, modified skin score had come down to 15. You can see the remarkable reduction in her swelling and her joints and just the movement. She used to be an avid golfer and couldn't golf, of course, with her pre-self, but really back to golfing and enjoying her life. And she just, this was her quote to me after sharing her after pictures. So definitely has had an impact on her quality of life. And she still continues in follow-up. She's actually not in my transplant clinic anymore because she's too healthy for me, but she still follows with Dr. Katsumoto for just maintenance checks. And then scleroderma in terms of next steps in terms of treatment from a transplant approach. So, so we do have the auto transplant now as a recommendation from as a standard of care option for advanced sclerotic patients. But it still has relapses. There are, depending on how you approach it, so the myeloablative does seem to have the best impact because it probably has the intensity to eliminate those autoreactive cells in the upfront, whereas reduced intensity, which were the other two trials I showed, ASSIST and ASTIS, did not fully achieve that probably, and so they have 34% 3-year relapse rates. So how do we improve on that? So next steps had in the auto transplant world would be was this STAT trial, and this recently closed to accrual. But this was where they added MMF as a standard maintenance 2 to 3 months after the auto transplant. And maintained it for 2 years to try to continue the relapse prevention from relapse. The outcome, which is not, will probably be reported now that they've closed the study, their event-free survival at 5 years hopefully will come out. There is another study called the UPSIDE study, which I just recently looked up. I think it's not something we are involved in here. It is a European trial. It's looking at upfront auto, not waiting for, so severe symptoms, but bringing it earlier and comparing it to Cy plus MMF maintenance. So that's an interest, that is because of the safe, we do think it's still a safe procedure to do that. We can push it earlier in the course of a patient's treatment history. And then finally, there's allo transplant. So that's when a donor donates the stem cells. This could be potentially curative. What we're trying to do here is replace the autoreactive immune system with the healthy donor's immune system. So totally replace, not using the patient's own cells. So you could see that has potential to be very impactful. But again, this is a difficult thing to propose. It has its toxicities, of course, of a graft versus host reaction that you don't see in an auto transplant, and so really should be only done in a clinical trial setting at this point. There were some attempts of allo transplant, as shown in the table here. But again, very small, N of 2 and multiple diseases, not just scleroderma in the other one. So, and again, GVHD was up to 40% in the allo transplant arm. So certainly, these are 2019, 2006 studies. So there are innovations in transplant now, and even at Stanford, we have what we call graft engineering, where you use a manipulated graft that reduces toxicity while still maintaining the effect of the allo transplant. Perhaps it can be looked at for autoimmune diseases as well. And then finally, the evolving cell therapies that were referred to in Dr. Katsumoto's talk, and probably you'll hear more and will hear more from Dr. Meyer. But CAR T cells, these are those engineered T cells. that could be used to create that profound B depletion of CD19 that could serve the same purpose of creating an ability to, modulate the activity after depleting all those activated pathogenic immune cells from the patient. There is a phase 1/2 study that is open for CARs against CD19 for scleroderma that is open at Stanford. We just had the first patient at Stanford get infused and finish her 10 days after. And so far, so good. So more to come. Very, very excited about that. The one thing is, probably if you were to compare, transplant does the same thing. It's just it's a big depleter. It's pan depleting, honestly. So this is more targeted. That's the hope. But it is a new therapy, so we are still waiting to see how this works. And then new concepts. So new concepts at Stanford in terms of scleroderma treatments. I work with Golinda Wernig in the laboratory for her interest in fibrosis. So I also work in research in graft-versus-host disease, which has a fibrosis component to it that perhaps overlaps in part with scleroderma, that it's helpful to learn pathogenesis from the science. And so she has shown that T cells that activate fibroblasts, she has found a pathway where the T cells activate fibroblasts that upregulate the transcription factor Jun, and that this Jun, which is shown here in the figure, actually upregulates expression of IL-6 and CD47. And IL-6, as you know, perpetuates inflammatory responses. And CD47 is actually present on macrophages and prevents is present when it's present, prevents the macrophage from eating the diseased fibroblasts that we see in scleroderma. And so the therapeutic approach would be attack IL-6 as well as 47. So IL-6, if you block it, you could block the inflammatory response. But if you block both IL-6 and the CD47, you may be able to prevent the fibrosis as well, and maybe even reverse it. And she has shown this in mouse models, so that it's in that phase right now. The second lab working in scleroderma is Dr. Maffrey's lab. He has looked at the defect in early B-cell tolerance checkpoints being associated with many autoimmune diseases, including scleroderma, and that there is this innate immune receptor called TLR9, which has a defective expression, but that it is required for central B-cell tolerance, which we think is defective in autoimmune diseases. So if we could somehow correct this defective TLR9 function and this impaired central B-cell tolerance, that would be a therapeutic approach for treatment, strategy for treatment. Again, this is preclinical. We have to find an agent that would be a good TLR9 agonist. Okay. And then summary, what's future and what's current now, what we know is that auto transplant, at least for severe scleroderma, has been the only therapy in the transplant side of things that's been demonstrated to improve long-term event-free overall survival when compared to the standard of care immunosuppression such as cyclophosphamide. International guidelines, so the position statements from American and European bone marrow transplant societies have supported auto transplant as standard of care. for scleroderma, and it should be performed at experienced centers that have that integration between your transplanters and rheumatology. Curative therapies, of course, though, still not in our grasp. Allo transplant could provide a potential for that, but again, it has its cautions with toxicity that we still need to investigate further with clinical trial. And then, of course, novel therapies, directions, the CAR T cells, CD47, anti-CD47, potentially, that's just sort of out there. And these are my acknowledgements. This is, of course, it takes a lot of team. These are all my BMT colleagues. Rheumatology, of course, Dr. Katsumoto, Dr. Lori Chung couldn't do what we do together, the transplants without them and their expertise throughout the course of the transplant. The basic scientists, Dr. Wernig and Dr. Maffrey, who I've been lucky to work with and learn from. And of course, the patients. And any questions? Thanks.
Thank you, Dr. Arai.
Sure.
Hi, my name is Leslie. I'm really interested in the allo HCT. So in comparison, well, I guess you can say, like, you know how stem cells help rebuild and regenerate for other people. In that trial study that you are having or hosting, how does one become like someone that is able to help with the trial, I guess, like, or what is a perfect candidate for you, and how do you find out, like, if you can help someone with your stem cells?
Okay. Yes. Okay. I think you're talking about how you find candidates for a transplant. And at this point, it would be auto or allo. Auto is actually standard of care considered, so it's been helpful for insurance coverage. It's not an issue, at least so far from the patients we've taken forward. And that has helped because of those position statements from the societies. But yeah, I think we are still following mostly the more refractory patients with diffuse sclerosis for eligibility, but as you saw, they are taking earlier diffuse sclerosis patients. And I think that that's the way the field probably should try to morph into, because that's where CAR T is trying to be. And I think that if transplant can be safe and it's the right thing for that person, that we can consider both pathways. I think it has more experience behind it, being an auto transplant versus CAR right now. But again, there are factors really to the patient and their provider of how much risk to take on. Or, do they have the support to get through a transplant? A transplant is, of course, like, it's never an emergency. It's always planned ahead of time and requires a caregiver to be with you when you go through the first 3 weeks. And financial aspects of taking off of work for the caregiver, for the patient, if they, those are all things that, though, is very familiar for us in bone marrow transplant, because that's how we treat the scleroderma transplants the same as the malignant tumor patients as well, that they need a whole team to get them arranged, to go through.
With her question, can you explain what you mean by refractory? What does that actually mean, so they can understand?
Right. So that's probably more to my rheumatology colleagues in terms of what they consider. And I think it's actually not necessarily refractory, but it's just, it could be not improving, right? Stably not improving. Stable, but not getting to the next level of function that you want. I think that probably it considers, to take on something novel, I think people would want you, we usually start at the more severe end of the spectrum and then move it earlier as we find it safe to do. So, yeah, I would say it is better defined by the primary rheumatologist where that patient fits.
Yeah. Great.
Yeah.
Thank you. And also to her question, I think you're also asking, like, if somebody wanted to be the person that gives the stem cells. So,
Oh, the donor. I'm sorry. Okay. Oh, so the donor, if so if we do move to an allo trial, then that's the National Marrow Donor Program, actually. That's the same, or actually we start with siblings first. So as in all transplants, we look at siblings are the primary choice because they have the most chance of matching to the patient. Then second is the volunteer registry, which is international, then could find you a donor that matches enough to go through the transplant. And then third choice is half matched. Those are pretty bold to go half matched in something that is still new. I would say we would probably start with just a matched donor for patients with scleroderma.
Thank you.
Yeah.
Anybody else have any questions?
Hi, Dr. Arai.
Hi.
My name is Dahlia Chalice, and I have a question about a clinical trial that had happened, and was wondering if you knew anything about it. It's called the Therapeutic Plasma Exchange, and it had been used on other diseases,
Yes.
including scleroderma, to a success, and it's less riskier than some of the immunosuppressant trials that have been going on, and had been accepted by some of the health insurance,
Okay.
but not all, because they need to include a larger trial.
Oh, okay.
And what it is, from what I understand, I'm not a
Right.
scientist, but it supposedly declumps the red blood cell, and it had stopped the progression on some of these scleroderma patients that I had heard about.
Okay, sure.
Did you know anything about that?
Not the direct trial, I'm sorry, I don't, but just sort of theoretically understanding what therapeutic plasma exchange does is it probably acts as an immune modulating therapy because we use it, plasma exchange, in other like immune cytopenias, immune thrombocytopenia, where there's abnormal antibody formation, and but it is a form of therapy that comes under apheresis, which is part of BMT. Overlaps with that service, but I would imagine it's because of that aspect of what plasma exchange can do, and it replaces with normal plasma, or so that's why it is an exchange of diseased plasma with the immune competent. That would be my thought. I don't know if Dr. Katsumoto knows more about that therapy, but yeah.
No, I think it's super interesting, and I think there definitely can be benefit in terms of just the replacing the autoantibodies. There may be other circulating factors. I mean, I think the one thing that Dr. Arai and I would be concerned about is, it's not necessarily a long-term fix. I don't know, right? Because ultimately, if you want to get at the cells that are making these we call bad humors, and so that's not it's just cleaning the blood, essentially. I think it's important to also be recognizing that there are potential risks. You need to make sure that you have like clotting factors replaced, because there can be bleeding complications or, other things like that. Sally's more familiar in the hematology world, but just to make sure they're doing it very safely, using very robust protocols so that you're not putting yourself at risk in any way. Yeah, thanks for sharing that.
Thank you. Thank you. Anybody else have any questions? When I was listening to your talk, though, you also mentioned host versus graft, and I thought it would be nice for you to elaborate on what that means.
Oh, okay. Oh, big topic. So graft versus host is when it only really becomes an issue when you use a donor graft, someone, not yourself as the donor, right? So then what sets it up is the body will naturally try to reject something that is foreign to them, foreign to the body, and that would be stem cells coming from a donor. And it goes both ways. So the host, the patient getting the cell would want to reject, which is called rejection. But then the donor cells coming in, which is your T cells, B cells, stem cells, that's that whole milieu of cells going into the patient for the transplant, also goes in to the patient, and they see your tissues as foreign as it goes in and wants to attack. And that immune dysregulated state is called graft versus host, where the graft attacks the host tissues. And it is initially felt to be T cell driven, but perhaps it is actually more PTB and macrophage driven as we learn more about pathogenesis of GVHD as well.
Great. Yeah, I wanted to make sure everybody understood when you were
Yeah.
mentioning that, so I thought I would ask. So
Right.
thank you for that.
Sure, sure.
Anybody else?
I would like to know what happens with a stem cell transplant, because I don't know. What's the procedure? And their own cells, so can you describe that for us? And again, it's probably a big topic, so.
Sure. Yes, of course. I apologize. Yeah, this is probably a higher, level talk of just the results, and I apologize for that. But yeah, the transplant itself procedure, when you donate for yourself, you can imagine that you have to, so we collect stem cells peripherally, so from your peripheral blood. But it is very much, but it is a procedure that we call apheresis, collection of stem cells from your body through a machine that spins out the component of stem cells that we want, and then returns the product that we don't need of your blood back into you. So it's a circuit. It's very much the way that platelets are. Healthy donors donate platelets. It's the same machine, but it's just the program is to spin out stem cell component. And it's about a 3 to 4 hour procedure. There is prepping for it, meaning you have to get stimulated with a growth factor injection for white cells. It's called granulocyte colony stimulating factor. That was the GCSF on the schema there. But that's 5 days of injection sub-Q under the skin. And the patient it's morning, you go, and then you go back to your day, but you get injections for 5 days. It can cause some muscle pain, bone pain, because it's expanding your marrow space to push out stem cells that normally live in your bone marrow out into the peripheral blood, so that we can collect you actually easily from the blood rather than go straight to your bone marrow for the harvest. And then on the 5th day of injection, you actually come to the Stanford unit and get hooked up for the collection. The cells are then, they come out in a little bag and then get frozen away for you from in our BMT lab. So it's on site at Stanford. They'll keep the cells for you. They have a long shelf life. They don't expire. It's just that typically we harvest and then we transplant shortly after doing that. So within about 2 weeks of collecting, you would actually come in for the transplant itself, which is inpatient. And like the schema wrote down, it's a combination of radiation followed by anti-thymocyte globulin and anti-T cell therapy and cyclophosphamide over a period of 5 days. And then those cells, then you're going to be depleted. You're depleting your B cells, your T cells, your stem cells during that time with that regimen. And you can feel very tired. Of course, it's standard chemo side effects of nausea, vomiting, some things like that that are more typical of chemo. That's why you're inpatient. And then the cells then come to your room, and it gets infused like a bone marrow, like a blood transfusion, actually, on the day of the transplant. And then, which can go over like 10 minutes, because they're frozen in there, yeah. And they just get thawed at the bedside. And then after that is just the waiting period for your counts to recover in the hospital. And that takes about 10 to 14 days for your cells to recover to normal again. And then you leave the hospital when that happens. And then we follow you sort of at a step down, not quite clinic yet, in what we call infusion treatment area, where you get sort of closely monitored. Your counts, you may still fluctuate a little bit right after that new cells come back. But after about the first 30 days post the transplant, you're feeling pretty normal. And it's just your immune system is not quite normal yet, because we knocked down everything, of course, and it's going to take about 6-9 months, even, well, actually, for this kind, we knock down your T cells and your B cells, so you're going to be down for about a year. And so you do have to be cautious. It's thankfully, there is COVID precautions. Now people are more aware of what that means to be careful in that first year. It doesn't mean you're an inpatient, but you are, and you're out and about, but you just have that little extra caution for that first year. You'll be taking infection prophylaxis to prevent infections like pneumonia and zoster, things like that. Yeah.
Thank you. Anybody else?
Yeah, that's hard.
So for the first year, would you be avoiding restaurants, avoiding concerts? Like, to what extent is the amount of protection that is needed?
Good question. Yeah, I get that asked actually all the time, even for my other patients too. It is the same. I think it's the same timeline. It's about, big travel, probably not for 6 months. I think it's a good 6 months until you really feel more, you get stronger the further out you get from the transplant. It's just the immediate month, 3 months, I would say you're the most vulnerable. Thereafter, we are, more, we allow you to do more things, get out and really want to do the things you like to do. It's not like physically you're feeling like you can't do them. So you should be encouraged to do activity to your toleration. I always say just no big travel plans until 6 months, but you can drive anywhere, just don't fly into another country or, before that, just so that we can keep track of you.
Okay, I think we're done. Thank you so much, Dr. Arai. I appreciate it. Thank you.